For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 4, Episode 5 of Surfing the NASH Tsunami. Our discussion with Dr. Tim Jobson of Predictive Health Intelligence in the UK starts now.
This week on Surfing the NASH Tsunami.
It's up to the end user to say, I know what patterns I want to find and what I want to look for. And it bypasses that process of waiting for somebody out there saying, oh, maybe there's a liver problem. We're actually going and grabbing these patients and bringing them in.
This would be a fire starter for pathways because it will inform physician and patients on the relative burden that is out there, and it will enable that a physician thinks down that line and thinks around metabolic liver health. And if he's not identifying them by himself, he has support from an validated algorithm that he trusts.
We need to protect data, but actually we don't need to make it so obstructive we can't find the right people with the right disease at the right time.
The careful and intelligent use of early data to empower patients to know when to ask about their own health should yield benefits really all over the place.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guest, Predictive Health Intelligence co-founder and director Dr. Tim Jobson, as they discuss the Predictive Health Intelligence model and what it can tell us about the future of frontline fatty liver screening and treatment, this week on Surfing the NASH Tsunami.
It's kind of remarkable that we're 5 episodes into the year, and it's January 24th as we record this, 25th when it drops, and this will be the first episode we've done that wasn't about NASH-TAG. And what's more remarkable is, from everything I hear, the footprint of NASH-TAG was deep and wide enough that that's appropriate. I've gotten some comments from you folks, which have been great, and everybody I talk to wants to talk about NASH-TAG. So tonight we're going to flip that script because we're going to talk about something very, very different from NASH-TAG, but really, I think, exciting and interesting. We have with us Dr. Tim Jobson, who is a co-founder and director of a company in the UK called Predictive Health Intelligence. I'll talk about this more after everybody says hi, but Tim brings one of the answers to a question I keep asking on this podcast. And so this should be a fantastic episode. Tim, how are you this evening?
Very well. Thank you very much, Roger.
Thank you for joining us. And then, of course, we have Jörn and Louise here with us. Jörn, how's your evening in Mainz doing?
Well, it's just fine. Feels like I've slowly settled back in my clinic days. So next travels are already around the corner, which brings in the madness of being an academic clinician, I guess, but also the fun about it. I'm very excited about this session here today. And thanks for joining us, Tim. I'm looking forward to your thoughts about how to tackle this health problem.
That sounds perfectly reasonable. And then in her last podcast appearance before she gets on a plane for 24 hours tomorrow and flies back to Australia, we've got Louise. How are you this evening?
Oh, very well, thank you very much. Trying to tie up a load of loose ends before I go. And it's great to see Tim and Sean again.
For anyone who knows how to send a fast podcast, Ms. Campbell was just miserating actually, since she's the only one to miserate on the quality of the food she's likely to be eating on the plane tomorrow. So for anybody who's got fast feeding on 24-hour plane ride tips, please send them to questions@surfingnash.com. I will get them forwarded to Louise immediately, and you might save her day tomorrow. Now, I mention this in part because next Monday I will be on vacation, and Louise will be doing a podcast we've not done before, which is about fatty liver in Australia. So we're all excited to hear how that goes. And I'm going to be fascinated to see what hour of the day they find that the Australians and Jörn can all collaborate. I'm thankful that I don't have to be part of it.
No pressure.
That'll be a lot of fun.
I don't know what hour it's going to be. It might be a lot of fun. So Tim is a co-founder and director of Predictive Health Intelligence. And do all of our listeners a favor. Take a couple of minutes and tell us a little bit about your background, what you're doing right now, all the things you're doing right now, how you got there. And then I'll have one question for you when you're done.
Thank you very much, Roger. So I'm a consultant gastroenterologist working in the National Health Service in the UK. I have special interest in liver disease, which has developed over the years, and key interest in chronic liver disease translated into a question. How do we find the patients we know are out there that we can't see, that aren't being referred referred to us that need treatment, that need intervention. So in addition to the day job, about 5 or 6 years ago, we started looking at this in a number of ways locally. How can we improve care pathways? How can we set up our clinics to find the patients before they just become one of the statistics? So that the number of years of life lost, the late presentation with decompensated disease, this is much true for us as kind of the whole of the Western world, really. And we started looking at what data was in our systems, blood test data going back many years, and it really becomes clear that we're missing something. So there's plenty of patients who've had blood tests going back many years, and they're not being referred. So not being investigated properly, they're not being referred to hepatology services when they need to be, they're not having the right interventions. And I guess the very first question when we looked at that was, well, why is that happening? And one of the reasons is because healthcare services are disjointed. Blood tests could be done one clinic one day, later that year, completely different clinic, another blood test done. Nobody's joining up those pieces. When they come to liver clinic eventually, or they get admitted as an emergency, yes, we take stock, we look back, we see all those blood tests over years. So we started looking at how we could analyze that data in a really straightforward way that identifies the patients in need of intervention. How did Predictive Health Intelligence come about? Well, I've worked for many years with my co-founder, Neil Stevens, who's director of IT in the NHS before he went on to work for himself as a management consultant, doing a number of projects supporting really IT development within the health service. We were just chatting about the problem. How do we solve this problem? How do we turn this huge pile of data into something that's really accessible and accessible to the healthcare teams? So I think everybody knows there's a huge amount of data sitting in our systems, and clever analytics can delve into that and find some really intriguing insights and find the answers. But we wanted to turn something that could be used on a day-to-day basis by healthcare teams, by researchers, by academics, everyone. We applied for funding, so we were really lucky to get National Institute of Healthcare Research funding for this project, and that came in back in January 2020, which was interesting timing because then there's this funny virus started going around, and we were a bit struggling through the first lockdown to get going, to get underway, and we eventually started the project in August 2020, and we got funding that will last till the latter part of this year, really, on the core project. And during that, we have taken the data and built a system around it that does just exactly what we set out to do. Identifies individuals, identifies cohorts of patients who have specific patterns of blood tests that really indicate they need intervention. So that's what we did. So I dropped part of my work in the NHS. We set up the company to create the software, working with software engineers, and build a system that works. And that's where we are today.
Great. And we'll want to hear more about exactly how that works in a little bit. It strikes me that you tread halfway down the path that Louise followed out of the NHS in pursuit of greater impact on liver. So we've got one and a half of you. Louise is out. You step back. You and I got nothing to do with this. It's all right. We're on a page of our own.
Not immediately, but it's a lot of questions Tim has been asking himself, that I'm dealing with in everyday clinics. I'm looking forward to share some of my thoughts and views. One of the big differences is obviously the NHS system, which has a little more different structure, let's call it that way. I think the German system is set up a little bit more liberal. The downside of that being data is not as well exploitable across different practices or patterns, but that's probably something that was also true for you in the beginning, Tim, and it'd be interesting to learn how you overcome those challenges. But anyway, it's a great approach, and I think much needed in many situations of liver disease.
So we can let our audience dangle with that thought 1 or 2 more minutes before we go back to what Tim's done. Tim, first of all, a question for every first-time guest. Something we wouldn't know about you that isn't self-evident if you didn't tell us. And the last answer was somebody who played tuba all the way through college, but we've had answers that are a lot more interesting than that as well. So what you got for us?
So my favorite place is the Greek islands. That's where I'm really at home, interestingly. I'm born and bred English, no connection to Greece whatsoever, but I'm never happier than when I've rented a small boat and sailing around.
Fantastic. Do you have a favorite island?
I don't think I really do, actually. Every time we go, we try and explore a little bit. My last trip was to Kos, fantastic island, but it's the small ones, it's the little ones, it's the backwaters that you can find, tiny little islands just with a few thousand people on them and some lovely little tavernas to hang out in and stuff. So, yeah, it's lovely.
Yeah, I'm sure that's right. So at the risk of giving myself up as being not as pristine about liver as I should be, some people who listen to podcasts and friends know that I collect a whole bunch of wine. Do you have a favorite Greek wine?
I tend not to drink the Greek wine.
Yeah, okay.
I'd probably go all the way to Greece and buy good imported wine or the local beer.
Well, the local beer, okay, but I can send you notes on Greek wines I love, not on this podcast right now. So with that, why don't we go to icebreakers? One good thing that's happened in everybody's lives in the past week. Brave one, go first.
Oh, I'll go first.
Go ahead.
I got the final result of my nutrition coaching course, which I've passed. So I can now be a nutritional coach.
Congratulations.
Yes, I just thought I'd put a bit more padding around the knowledge that I've got. But it has taken me 18 months to do that and a number of assessments. But actually, it's been really valuable insight into diabetes, elderly care, the different diets at different generational stages and exercise. And yeah, it's very rewarding, I suppose, particularly doing what we do now.
They must have been covering airplane menus too, if you're concerned about your food on your trip.
But interestingly enough, they didn't do airplane menus, but NAFLD wasn't mentioned once. This is a nutritionally approved course through a college. So my next thing is to try and get NAFLD and NASH on the agenda, or to be mentioned in nutritional courses rather than just diabetes and heart disease. The usual suspects. Good.
So now, as Jeff Lazarus points out about WHO, you can get the word liver in there, not as that's the end of the word deliver, but as a word in its own right. That's excellent.
The funniest thing going on in my life at the moment is teaching my 17-year-old daughter to drive in the ice. And as long as we stay safe, I guess it's funny. If we don't stay safe, then it becomes less amusing. That's really enjoyable. I know you said one thing, but I'll go with two, because we have a team of, they're called junior doctors, doctors in training, however you want to describe them. And sometimes they just amaze me with their brilliance. So we're not a big teaching hospital with massive teams to help with research. But it's just sometimes they sit down as a team of 6 and just come up with the goods. And that's what they did in the last week. And give them a task, and wow, they just get on with it. And it's a real privilege to work with people with that degree of enthusiasm and energy.
Yeah, I'll keep it quick. We had a good amount of snow back here, and I did some extensive sledding with the little ones over the weekend, recovered from the bruises of that, and I think that was my highlight.
Being a dad can be a contact sport, huh?
No motorized vehicle for mine yet.
That's good. At that age, there better not be motorized vehicles. That would be a scary thought. I guess mine is to come, which is I leave on Saturday for a 5-day weekend in South Florida, a long weekend in South Florida, completely off the grid. No radio, no email, no nothing. Just eating and walking around and going to the beach and soaking in some warm weather. So I am prospectively excited about that. My other good one, I guess, would be that after trying and failing to meet up with Tim at ASLD in Washington because I did not have the correct address to the restaurant where they were holding their reception, I'm glad that we're able to get you on the podcast today and we can actually hear about what you do. The reason I'm so excited about this is that we've talked on this podcast a bunch about how to make use of frontline tests for screening and treatment purposes, and the idea that it would be easy to do that in the U.S. because EHR, electronic health records, are so entrenched. Harder everywhere else. So when Tim and I were talking before the episode, he made the point that this is not an AI neural net kind of a solution, but I think that's a good thing because the data probably don't exist to implement those solutions in very many parts of the world. But this is an intriguing one. So Tim, do us a favor. You did a really nice job of a preamble of how you got here. Take a few minutes and tell us about what you're doing, please, and how it works.
And I think also right up front, it is a combined informatics and a clinical program simultaneously. So it's about developing new clinical pathways as we go, and I'll talk about some of those in a bit as well. What we wanted to do is take the retrospective view, essentially, of the potential patients out there. So a number of programs of work going on, so the intelligent liver function tests, some proactive screening programs and so on, the SCAR Liver Project, they're looking at a steady trickle of patients coming in, and we're sitting there looking at the data and saying, but there are hundreds, if not thousands of patients just in our patch who need to be seen. We need to get that pipeline going. That's what it's predicated on, that the patients already exist. A kind of sea change in how we think about referrals of patients into the unit, in that we're not waiting for referrals. We want to go and find the ones that, when they come to us, we'll recognize the ones who are ill and we'll treat them and we'll do the right things. How do we go and find the ones that, if we don't do anything, may never get referred, may never come to attention until they get decompensated advanced liver disease? So in terms of the technical side, it was about taking all the data that exists as much as we can, getting the right approvals in place, because that's always a challenge about use of data and secondary use of data, and then cleaning it up, tidying it up and curating it and putting it into a system that now enables the end user, myself, clinical teams, other healthcare professionals, ask the system one simple question: show me the patients who've got these 3, 4, 6 patterns of blood tests in the systems. It is slightly different from a lot of other approaches where you're looking at a single point in time, saying, what's the fib for today? So show me everybody with a high fib for. We're going a little bit more detail on that. We're looking at trends over time. We're looking at cumulative results. We're looking at area under the curve. We're looking at, as I say, trend lines. So you can do exactly, almost replicate what we're doing in clinic. When I look and see a liver patient in clinic, clinic, one of the first things we do is pull up the chart of blood tests going back 5, 10, 15 years. And I've had that conversation many times with patients, and they're saying, well, hang on a moment, you're saying my blood's been abnormal for several years. Shouldn't I have been diagnosed earlier? And the simple answer to that is yes. But we know they don't come to attention, and we know all the reasons why that is. So we created a system. It's got around 200 million blood tests from our local patch for about half a million patients. And we created a system worked around that would really quickly identify cohorts of patients, individual patients that met the criteria that you put in as a clinician. Quite specifically, we're not asking the system, show me patients with diagnosis X. We're not asking, show me patients who've got PBC, show me patients who've got NASH, show me patients who've got X, Y, Z. We're just looking for patterns, and it's up to the end user to say, I know what patterns I want to find and what I want to look for. And obviously the team who I'm working with, we're going through quite a lot of work validating some of those patterns and publishing that as we go. So that's all the system can do. Once we generate a cohort of patients, we then can look into more detail and then just start recalling them for treatment. And it bypasses that process of waiting for somebody out there, whether it's their primary care practitioner, another specialist, another area, saying, oh, maybe there's a liver problem, and sending them to us. We're actually going and grabbing these patients and bringing them in. And so that's what we're doing with the data that's there. And it's incredibly powerful, and it's a new way of treating patients. So I said, this is a new clinical pathway. It isn't slightly new. It's not brand new in that we do screening programs all the time, but it is slightly different from a screening program in that we have to have that conversation with a patient. You've had these blood tests sitting in the system. Nobody's really twigged what they are telling us. But when we look at them as liver specialists, we say there's a pattern we recognize, and invite them in for treatment and intervention, whatever that might be.
That's really fascinating. Louise, I've got a few questions, but let me let you guys go first.
Tim, the clinical situation you're describing is something I can reflect on and that I've encountered myself. And I think you're doing a great job in trying to tackle that. Two things resonated with me. One question was, you have these patients, and I do see them in clinic, that said, well, why doesn't anybody look at my liver test before? Did you notice a change in the way the patient responds to the diagnosis after the referral through your pathway versus the traditional? Have you looked at, maybe you get more early disease stages or more milder stages? You could say, well, maybe we get an over referral or something. Have you done some sort of comparative analysis before and after, something that you like to share with us here?
So it's early days right now for that. We fully intend to do that. I think at the moment we're just testing out the pathways on a sort of improvement methodology. We need bigger numbers to really comment on that. What our initial findings are that people are responding really positively to this. The patients that we have seen so far have all said, this is a great initiative. I don't mind receiving a letter out of the blue, a phone call out of the blue. No, this is a really good thing. Yeah, it nudged me to improve my liver health or whatever it is. That's the kind of feeling we get. We haven't as yet had any complaints saying, I really wish you hadn't done this. We will, I think, as we expand the numbers. I'm sure we will get people who will say, no, this is not a good idea. I wish you'd left me alone. And we will get that. As the numbers grow, we fully intend to analyse it. And in terms of downstream treatment, response to treatment, everything that comes from the moment they come to a liver clinic, everything should mirror pretty much what would happen to them if they've been referred by a GP, by another specialist. So downstream, we're not expecting that to be massively different. Maybe these people will be better engaged. Who knows? Maybe they'll remember that initial consultation where they really benefited from this process. I don't know. We'll see.
Yeah, thanks. The other thing that I felt interesting, and let me just recap that I understood this correctly. This is an algorithm that calculates from a number of variables it has available and even looks at, you said slopes, like I would do if I have a patient in front of me. I'm trying to pull these things together and look at certain, not necessarily always the same values because I don't have them all. So it's more of a flexible or plastic algorithm, if I understand this right, and even calculates changes over time. And how do you go about technically about it? Does that require a lot of computing powers, or how is that done?
Yeah, so you're absolutely right. It looks over time. So a typical example, we looked at the ALT chart. A patient's ALT is up for a long time and it's significantly elevated. The more it's elevated, the longer it's up, probably they've accumulated more liver damage. So take that kind of concept, and mathematically that's just the area under the line. So that's just the integral over time of that parameter. The other thing you might notice going into clinic is seeing a patient whose platelet count has started falling. You're going to go, well, there are other reasons why platelet counts, but actually that's potentially an indicator of really advanced liver disease or portal hypertension. So those are the sort of parameters that we calculated. And we actually looked at the power of those in the data we published in Washington, and looking just at the area under the ALT chart gave an odds ratio of about 18 for predicting liver disease. So extremely powerful. And then combining it with with a trend in platelets, that gave an odds ratio of something like 25. So that is kind of very different from what we've been used to doing it with a single point in time. How do we do it? It's more about prepping the data for the possible range of clinical questions. It's not constrained. There are a huge number of questions an end user can put in. I think last time we looked at, it's about 10 to the 16 questions they can put in. So it's not a limited system in any way, but the data is prepped in the way that we look at blood tests in the clinic. And I think that's the key. It's what we do with the data when we've got it and prep it so that then the queries on that data can run really quickly and generate a cohort of interest in seconds. Now, if we go up against the limitations of what the computer do, then we have a refresh process and it'll do some more calculations in the background and generate more data, and that can take a bit longer. But for those things there, we simulated them before we got into the project, and it's going to take a reasonably powerful desktop computer 3 days to compute it. And now it's returning it in 3 seconds to the desktop, so that's great. The approach has worked. And as I say, it's predominantly about prepping the data. The number of IT projects over the year, and what's really different about this is I'm working so closely with the developers who are creating the system. So we meet every few days, and each little bit that as we've built it over the last couple of years, it's been the clinical input and the IT specialist and developer building the system so that it really is honed to what clinicians are going to want to ask it.
It sounds like a fantastic system, and going out and seeking out patients. The one question I would have on that is we often get met, as you know, Tim, and I'm sure it's the same in most medical systems, don't go looking, because if you go looking, it's costly. So have you come across any barriers to actually physically going out to look for patients within the region?
So absolutely recognise that barrier. I think one of the things we're doing at the moment is a full economic analysis of what the impact of this system is and scale it up by the size of population you're looking at. It will have an economic impact, and yes, it will front the costs, but downstream it's going to save a huge amount of healthcare costs because these patients end up extremely sick and extremely unwell. There will be barriers to overcome. So far, we've sort of got the green light to go ahead, but we need to, as we develop the program of work further, we need clearance to go and do that. Some of these chronic liver disease patients, when we actually look at the amount of resource they're taking, it's a very small amount of our time as a liver team compared to a handful of sick patients on the unit with decompensated end-stage liver disease take up far more of our week than the patients coming to clinic. But yeah, we have to look at it. If we don't invest, though, the future costs are huge. And we're seeing that right now. We're seeing that a lot of the acute care crisis, so they're feeling it in the NHS, the acute care crisis, is driven by chronic disease that has reached its end stage. And if we'd been treating these patients 3 years, 5 years, 10 years ago, we would be in a better position now. So now's the time to start dealing with what's coming in 3 years or 5 years, 10 years' time. And right now, it feels like pushing on an open door, to be honest, and have these conversations. We've had it with our local integrated care board, who effectively runs the show and commissions all the healthcare across our county in Somerset. They are really positive about this approach because we simply have to do this for liver disease and others.
No, and I agree with you. And when we see it, when we bring people in, we often change behaviour, which stops them coming in repeatedly to hospital and healthcare costs. Is there an ability with the system to calculate later on in how many comorbid conditions that some of the patients came in with later disease? So the more advanced NAFLD and NASH, how many, the percentage of diabetes was there? What was the pre-diabetic population? Is there a way to look at the metabolic spectrum rather than just the liver in the assessment of the patient and those additional cost savings if we can improve diabetes and cardiac outcomes?
So I think there's kind of two bits to that. Firstly, yes, obviously those parameters are so relevant to liver disease. So that the metabolic liver disease is part of that big spectrum of disease that ends up with patients down the line with cardiovascular disease, with diabetes, with chronic kidney disease. So we brought all those variables into the system at the front because they're so relevant to our patients with liver disease, what their lipid profile is doing, what their glycated hemoglobin is up to, and so on. So that is critical. How do we measure that impact? I think that's the second part of your question, really. How do we measure that impact going forward? That question's not yet answered. I don't know how we'll really predict that impact, just that we have to do it at scale. And we need to be identifying people much earlier in that metabolic pathway. Where the first bit of fat storage in the liver, that's probably the start of a journey through insulin resistance, weight gain, down to diabetes, chronic kidney disease, and so on. So it's about identifying those people right at the front. As part of the project, we are looking at doing some modelling now and seeing what the potential impact of this, because our initial look at this is huge. The potential impact on improving health outcomes by identifying people and targeting the right interventions And again, as therapeutic agents come to market, that's going to be a really important step as well.
Yeah, I would say it's not only the therapeutic compounds that are maybe not available today. I think we've discussed in many aspects of this podcast that liver health has an impact on global health, quality of life, metabolic control of certain conditions. From my perspective, even if you don't have an antifibrotic for NASH, you'd be able to manage comorbidities better if you understand the cause of the elevated liver function tests, or reassure that statins could be given, preventing the next heart attack. There's just so multifactorial that I'm fully aligned with you, the strategy trying to, even in the absence of an antifibrotic for NASH, you should manage these patients.
So, it's a huge problem, isn't it? So the liver component of that metabolic syndrome, the liver health issue, often it's so overlooked. It's just accepted. Oh, your liver test will be abnormal because you've got diabetes or whatever it is. And what that's telling you about the person's overall health is often overlooked. So part of this will be to educate people as well. This is a huge cohort of people who need intervention to stop them getting sick. In terms of what we can do in terms of spreading the system, one of our founding principles that we will keep the input to the system really simple. So the data that's required really is very simple. And as long as the blood tests have been done and we can extract that basic data, we can do the rest, because data is stored in all sorts of different ways and there are all sorts of different errors that creep in, and that can be extremely time consuming for anybody analysing the data. But actually we take care of that. So the principles can be taken anywhere that can do blood tests.
That makes sense. If you go out to sub-Saharan Africa, for example, which is I think where Louise just went, you talked about having sufficient computer power to get what would take 3 days on your desktop to take 3 seconds. Now, that's not huge computer power in today's world, but it's probably more than you can summon in a decent amount of the developing world. Or is it easier to do than I think in terms of raw computer power?
It's all done in the cloud as well. I think that's another advantage of the technology that we're using at the moment. So all our processing is done in the cloud. It's going to be done anywhere. It can be done anywhere in the world. We have the only issue associated with that is the security, the governance of the data. But we've dealt with that because of the way the NHS is set up and the way we govern data and the health and social care network. What we've done and the approach we've taken, I think, has meant this isn't done by raw computing power. Yeah, and it'd be interesting to take the system we built now and put it on a desktop computer and see what it would do. I don't think it would be that slow. It certainly wouldn't be the 3 days. What we're doing is taking traditional desktop tools, posing those same questions of that sort of data set, and they grind to a halt. That's the point. Actually, it's the design element of this that has speeded it up far more than raw computing power.
It almost feels to me, speaking as naive, as if what you've done is you've taken an optical validity test and you've really validated it, right? If I understood what you're saying, it was that if Jörn could look at the set of data that you were looking at for an individual patient, he might or you might come to the same conclusion. Your system will. It's just that you don't get to look at that much data aggregated and you don't get to look at it this often. So you've really improved the throughput speed for some pretty straightforward analysis.
Yeah, I mean, we're not doing hugely complex data processing. We're certainly not applying any machine learning at this stage. Mm-hmm. I think there's potential fascinating ways of doing that in the future, and there's huge projects that could spin off this. But you're absolutely right. The actual calculations done are repetitive and simple, and we've just got a computer to do them for us and do them in the background so that we can then just take a view on the data and say, show me the patients with that particular pattern.
Well, which I think is fantastic. The challenge that I think the world faces is how to do exactly what you just described. We're going to be processing in a world where we have medications. There are going to be, this is a technical term, boodles of patients for every hour that hepatologist has to treat them. So the ability to get people in early and to get them processed simply and triage, not perfectly, but triage quickly and appropriately. I mean, that's the whole logic behind FIB4. Are you planning to take a look at how this stacks up against a more traditional pathway approach, say FIB4 FibroScan or FIB4 Alpha approach in terms of being able to get to the right patient or being able to get to that patient more efficiently?
Yes, definitely. So going forward, what are we going to do with this system? There are some obvious pathways where we just get on and implement it. I think that's a fundamentally good question. Can we target those screening interventions better using longitudinal data? I think we can. We intend to study that. So I think that needs a more formal setup for a study, but it's an obvious way to go because probably population screening with FibroScan would yield results. But actually, that's an awful lot of FibroScans. And so if we can target patients based on what we know already about them, I think that's going to be much better. It leaves a question about the patients who've not had blood tests and where do we go with those? And should we encourage more kind of health checks, MOT checks as you go through life, every few years have a blood test and so on, which is not universal for certainly quite a lot of groups within the UK. So that may be part of the future as well. Right. And the other thing is about recruitment for studies. So yes, we want to do our own studies saying, can we really risk stratify these patients and target them for intervention and target them for FibroScan or whatever. But this is an extremely powerful tool for finding cohorts of patients for research studies as well. If you define the group that you want, if they exist, if we can define them with blood tests, we can find them really quickly. And this will ramp up recruitment to liver studies as well. It's a huge potential. So rather than waiting for that steady trickle of patients across multiple sites to try and recruit patients, it's really simple. It's the press of a button. There's a potential research cohort. We can go and talk to them and do they want to be involved in a study?
That's an obvious gain because enrollment's been slow in some of these and barriers of recruitment. The other thing I was thinking of when you just mentioned, we don't always have all the diagnostics available in all settings or maybe at all time points. Have you thought or looked into some sort of medical note automated processing where you can pick up on, let's say, identify a scribbled note of a physician that this patient has received a blood transfusion in the 80s and he's therefore at risk of having hepatitis C, and this type of extraction from medical records, which could need a lot of more power or also data safety protection troubles, but not only acting on labs but also on some clinical nodes, if that in theory could that be implemented?
Definitely. So we've talked about that a number of ways. Like I said, this sits in that group of things that we are thinking about for the future, using more machine learning to analyze our data. The natural language processing question, I think that's fascinating. There is all sorts of potential taking this approach. You could, for example, yes, import clinical notes. You could do something more simple, import ultrasound reports. And then the question that we put to the search tool is show me all patients where there is a suspicion of fatty liver on an ultrasound scan. Simple question. We can use natural language processing to generate that. We have kept our project really simple, partly because we really need to demonstrate that it works in the first round. And getting access to data is a challenge, and we wanted to make sure that it was very focused and narrow so we weren't spreading the kind of the net too wide at this stage. But yeah, another fascinating line of inquiry for this sort of approach. And the natural language processing technology is that. It will do that in the background, and then the clinician can say, what I'm really looking for is this, and sift through 500,000 patients. And the intention, obviously, is we'll go work for a much bigger footprint. So out to the whole of the Southwest would be 5 million. Across England is 50 million. And that's the kind of footprint we need so that clinicians in their area can say, find me those patients that fit into that group. And we have to, every time we do that, design those clinical pathways. Because I think the great danger is we'll find, there's several thousand patients here who need treating. What are we going to do with them? And it kind of goes back to Louise's question earlier on, doesn't it? We need to know what we're going to do. Are we recruiting for research studies? Are we actually going to have capacity to intervene? Are we going to delegate that intervention back to primary care? What are we going to do? And I do think, kind of as an ethical doctor, that's a really critical question to ask before we start generating huge cohorts that we don't know what to do with.
I was going to say, you said the patients responded very well to being called in. What were their main questions? What information did they want? Just as a guide for education, sort of, was it, I've never heard about the liver, or I have always had these problems, or what was their general sort of interest apart from being called in?
A very common question is, am I drinking too much? That's, I guess, we'll take a history and we'll come to conclusions about that. So the question that came was, what have I done wrong? Have I done something bad? Because liver disease has a stigma, doesn't it? Is this just alcohol? And of course we know it's not, but that is what people associate in their mind. So that's a key question. Is there a treatment? Yeah. And what's the treatment? And so on. And those questions kind of morph into just a standard consultation. I think initially we were sort of heading off quite a lot of the questions. We really carefully designed our communication stuff that goes out on our website and the invite letter to come to clinics so that people are primed and say, this is what we're up to. Complete transparency at the front. We've access data. We want to go and find people who, if we don't find them now, are going to get ill in 3-5 years' time. And explaining that at the front, I think that's been hugely helpful. So that kind of heads off some of the more difficult questions. And I guess the really difficult question we've not yet come across, but we will, is what on earth were you doing with my data? Before we even started the project, we got some patient and public reference group together and asked a lot of questions of that group. And it was really interesting. When we presented the ideas, what we planned to do, it's all this data, and it was not, are you really allowed to do that? It was, why aren't you doing that already? So the commonest question that we get asked from our patient and public reference group, which is a great part of the project, they're still heavily involved and challenge us regularly about the direction of the travel of the project and help us with all our materials and everything, is you need to be doing more of this, you need to be doing it faster. Why are you taking you so long? Is a question that we get all the time. And I think that's very different from the official line, which is, this data data is top secret. You mustn't touch it. It belongs to, it doesn't belong to you. You mustn't do this, which is kind of the official line.
That's fascinating and not surprising, but really, really interesting, I think, about the patient reaction. I have a question for Jörn, going back to your last comment for Louise's question, which is, Jörn, how do you see this fitting into some of the work that you and Jeff and others are doing, Lazarus and others are doing right now around pathway development? Because the two thoughts I had throughout this conversation is that one, and then the question about every time we get patient advocates on here, I talk to people about why aren't they doing more to push ALT as a part of every standard test ever done for everybody? And this would be another argument, I think, in favor of that. But let's stay on the pathway piece first. Where do you see this fitting in?
I think this would be a fire starter for pathways because it will inform physician and patients on the relative burden that is out there, and it will enable that a physician thinks down that line and thinks around metabolic liver health. And if he's not identifying them by himself, he has support from an validated algorithm that he trusts. He will start managing these patients actively, as Tim and his colleagues are doing. As such, I think such a tool would be very, very helpful. We had John Dillon with us last year, and he dealt ILFT, which, I don't want to compare them directly. It's a different setup, but I think it goes down the same line. Physicians and patients are not noticing liver disease in routine care. If we have tools to augment the recognition, in particular the ones that are urgent for management, it will expedite and start building these referral pathways. That's where I'd like to come back to you, Tim, and congratulate you and your team for doing that, and because I think it's crucial to really start managing liver disease more actively than we're doing today.
So, Jörn, I couldn't agree with you more, and let me draw that line a little bit further. I'm going to take a lesson I learned from Louise also. So, Tim, the last comment you made before my question was that people treat this data like it should be top secret, and in health systems, people also act like the doctor should be in charge. And one of the things I think we're learning in liver disease over and over again is that if you put the data out to patients with a way for them to understand what's going on, they will do the right thing. They will take care of themselves. And if you've ever sat in a focus group watching people who've had liver transplants weeping about what it felt like to find out that they had severe liver disease when 15 years ago somebody could have found it on a blood test, then you understand how disempowered patients feel at the back end of this process. I believe that the careful and intelligent use of early data to empower patients to know when to ask about their own health should yield benefits really all over the place. And to the degree that it small d democratizes or opens up the data processes, I think that's a good thing as well.
Everybody wants to have somebody be proactive about their health, and yet we're overcomplicating things by putting barriers in the way, and it's data protection. Yes, we need to protect data, but actually we don't need to make it so obstructive we can't find the right people with the right disease at the right time. The engagement that we get, 90 plus patients change their behaviour, or people, because a lot of the people we scan are choosing to find out about their liver health for the first time and be proactive. Every single one of them takes on it and changes something. And if they don't, you see the opposite, and then they tailor it back. Those aren't massive resources at times, but they're very well used resources. And I think this is where doing the financial aspects really helps us, because if we can stop somebody fronting at ED 10 times because we've picked them up early enough in that timeline, that's a cost saving that's not necessarily seen in a liver portfolio, but it is seen in a different department. So I think the implications of going for liver and metabolic health with a system like this is vast and huge if we really look at its potential. I had a question about, we often get told, what about the wrong person that you diagnose wrong? What about them? That's always used as an excuse not to proceed. I've certainly come across it with different areas. So that doesn't seem to be a problem that you've had, Tim, with any of the patients that you've had. You've picked them up. They may not have had the level of disease, or did they all have the level of disease you thought?
Yeah, so it's early days and not small numbers at the moment, but absolutely. And what we've done is down from that case identification moment onwards, we've just tried to mirror current pathways of care. So what would happen to you if you were referred by your GP is exactly what happens to you if I call you from this system. We actively discourage people from using this system. It's perfectly capable of being a useful lookup tool to make a diagnosis. You can look at the bloods and say, I know what you've got. But the reality is the process we put in place is once a patient's in the clinic, you use the traditional systems in exactly the way you would use them, because the same data is mirrored across all the systems, and we can look at it in a very similar way. So I don't look at our system when I've got a patient in front of me. I look at the standard hospital systems. I am not relying on the system saying this patient has advanced fibrosis and fatty liver disease, because the system can't tell me that. What the system can show me is this patient falls into that cohort where you were looking for those particular parameters that we know are highly associated with those conditions. that's all it's telling you. And I think that's a really good way. I still think black box diagnosis is something that most health systems and most setups are not ready for. There are so many hidden potential problems with that approach, because when the black box machine, the AI, the machine learning, the very clever algorithms come up with a wrong answer, not only do we not know how it came up with the wrong answer, we don't even know it has come up with the wrong answer. And it's about that transparency of data and transparency of data use. So that's our key approach to try and minimize that risk, that the computer diagnosed me wrong is not realistically significant. I mean, we could get that label. We can get that label. We could certainly recall somebody to clinic in error, if you like, give them a once-over, say, actually, I think you're really well, and sorry for taking your time. I don't think that's going to be a major issue. But I also think that sharing of data with the patient is hugely important, because that helps those conversations. It helps conversations about when somebody's ill, and it helps that conversation when they're well. And I do it routinely in clinic. I spend a lot of time turning the screen around in clinic, saying, these are your blood tests I'm looking at. This is the scan I'm looking at. That's the bit we're really worried about, whatever the conversation is. We've got to get people's healthcare data to them, 100%.
Did you get any pushback from the primary care physicians? Because obviously, by doing and looking at the retrospective tests, you're picking up where people have failed to detect in the past. And often that could be quite confrontational, or a patient could go back to the primary care physician saying, you missed this. Have you had any pushback, any concerns? Or have they welcomed it with open arms?
We've had very little. We had lots of conversation with primary care, and obviously primary care went through COVID as well, just as we were implementing the first pathways, and so that was really challenging. And so we essentially bypassed primary care. That hasn't been an issue, and I think partly that's because the way I think it happens and the way we describe it right at the beginning of the project is around the simple, huge wave of abnormal blood tests that come into a GP's inbox on a daily basis. How can they possibly know which is the right one to pick out and send to us? No, we write referral pathways and guidelines, and this is what a primary care person should look for, and this is when they should repeat the test, and then they should do a FIB4, and then they should send them for an ELF test. But realistically, my experience over the last however many years is that can never work for so many reasons. As I say, it's the volume of blood tests, but it's also, they see a different GP on a different day. They move practices. So we're stitching up the data right across the county. Doesn't matter which practice, which outpatient clinic, we're stitching it together. That view isn't available for the GP anyway. And I think when we describe it in that way, we haven't had all you're doing is pointing out our failures kind of challenge, and we're not. We're saying there are patterns, they're not seen, that's nobody's fault, because if it's somebody's fault, it would only happen occasionally. It's universal that these patterns are not seen. And then we go and look for the patterns and we see them, and then we can start managing it.
The one idea I had when you were talking now that came to my head was it's important that we share with these patterns potentially or the results with the patients too, because we empower them to act on their data. And I'm thinking back of a patient that I managed for a long time. At one point, he just stood up and said, well, I think you're not making sense to me anymore. And I kind of lost him on the way somewhere, stopped in short visits, explaining him to the depth that he would have needed that. And if I have more data to share with him, maybe this could have, I'm not saying that would have prevented this, but you have these situations where you lose your patient. If you have more time or support data to share, this could be something that's helpful also in this context. It's just a thinking.
Yeah, Jörn, I couldn't. One of those I keep having as I'm listening, and it gets stronger as I listen, is that we think about the need to protect data, and we got it about half right, which is we're protecting data from being used against you, but not being used for you if you were the patient. And somehow we need to make that distinction, that data about oneself is one's best friend. Data about oneself is not in the wrong hands, is not one's best friend. So the ability to make it easier, which Tim, the system seems to do, to make it easier for the physician to share, or the provider, nurse or whoever, to share data with the patient in such a way that the data is protected from the outside world, seems to me hugely, it's a really important dichotomy, and B, it's a way to drive that further. And I can see all kinds of cases for that.
And what we have to do, and what we've done, and wherever else we take the system, we're going to do the same. It's about bringing as much data about the individual patient together from all the disparate sources. And different health systems are set up differently for that, but by keeping the inputs really simple, we can stitch the data together from lots of different sources and make sense of it. And that's really important for the patient, that they have the whole picture, because if they just see the rheumatologist in the rheumatology clinic and they see their blood test results, that's not the whole picture. They just see their GP, that's not the whole picture. They need to see the whole pattern. And I guess that's where it started. It was patients walking through into the clinic, and while they're walking in, I'm pulling up the charts of all the data over time and getting that view. And yeah, really lucky in Somerset that our data sits in one system to start with. That isn't a necessary requirement for implementing our sort of system. It can all be merged together. But it really helps show the way as to what's really going to work and what's a powerful way of looking at data and a holistic approach.
But Tim, is it necessary to have the ability to integrate data from multiple sources, that is multiple practices or specialties simply? I mean, it doesn't all have to sit in the same place, but if you can't get it all organized in the same data set fairly quickly, is that a limiter for this?
I think there will be patients where it's fine. We've got some of the data, it's enough to come to a conclusion. Okay, so it's not going to be hugely, it's not going to be completely limiting. However, clearly, the more information from as more different sources that we can pull together about an individual patient, the better. And we already have in the pipeline the technology that kind of integrates across 2, 3, 4 systems. If a patient's moving around, so that if the same patient appears in an entirely different data set, we will stitch that together. And that doesn't happen at all. I mean, that's very uncommon. If you lived at the other end of the country, so if you lived in the northeast in Newcastle for a while and then you move to southwest and come to my clinic, it's pretty unlikely I'm going to be able to wade through your blood tests. Some of them will move with your primary care record, but most of them will be lost. But actually, with this sort of approach, we can pull all that lot together. Once we have the access, the data set we're using is really simple.
So how easy or hard will this be once you abandon Somerset for all and move to the Greek Isles in Greece?
I think we do the whole thing remotely. Yeah, we can run the whole thing remotely.
I was going to say, it's great to have physicians in this case think outside the box and apply the modern technologies and think about the problems we're facing and come up with a pragmatic solution, which it feels you have. And I understand it's being developed, refined. There will be data for readout, also cost effectiveness, and this is just fun to listen to you.
It is the pragmatics that's compelling, isn't it? I mean, we've been thinking, boy, the U.S. has all this stuff. What would you have to do to get close to it? And this seems at a very applied level to be very, very close to what we're talking about, certainly in terms of frontline screening. And you've made it fairly simple. Not easy, but you've managed to take it and simplify the process. And
I think some of the responses we had when we started explaining to people where we're going with this and what we're doing with this, it's almost like, that is so simple. It's just like, it's almost too easy to do. Reality is, it's taken quite a lot of work to make it work, but the concept is very straightforward. And I think that demystifies it for people and it makes it less threatening. This is really, really straightforward stuff. It's just making sure we can see everything about you and then which group do you fit into? Do you fit into the group that might have the disease and need to see a doctor, or the group that really doesn't need to worry? And it's as straightforward as that. And with all the data sitting there, this is a fantastic resource that will otherwise just go to waste. So yes, we've got lots of prospective programs to identify people as they come in, better pathways, better screening, better targeted screening and so on, but not wasting that resource that's just sitting there and finding the patients who need us before they come too advanced and we can't help.
That's fantastic. I'm a big fan of complexity theory, and one of the things that drives complexity theory is the idea that complication is the enemy, but complexity is the ability to take a lot of little pieces and draw a through line, which seems to be roughly what you've done here, taken a lot of disparate data and figured out what the through line might look like. So commendations for that. Closing question, different questions to different people. Where will this be in a year if everything goes right? And then to everybody else, where do you see the value of this once Tim's done what they've got to do over the next year? So Tim, I'm going to let you go first.
So in a year, there'll be two things at least. One is we are committed to using this in Somerset, which is great. So we're going to be finding our local patients who need treatment, and that's an ongoing program of work, and will give a great, immense satisfaction, I think, as we start to treat these people. I think additionally, this will be moving out to be a footprint of patients. And my ambition is that this is available to every clinician on every desktop. Where every stops and starts, I don't know. But right across the NHS, all of our clinicians, all of our systems should have this kind of data analysis at their fingertips, and they can find the patients for their specialty. For liver disease, particularly at the moment, that's where we are at the moment, but that should be there. And I guess the third thing is that this should enable more research as well, because not all the questions are answered. We don't know how to deal with all these people. And there are huge research questions and huge programs, and this can really accelerate the rate of identifying patients for enrollment in research. But the technology is usable. It works. We've cracked the big problems. It's very straightforward to implement. So I'm really looking forward to getting that 500,000 patients up to 5 million and then heading on 50 million and beyond.
Just keep adding zeros, my friend. 1 zero at a time. It really gets big pretty fast. Okay, Louise, your thoughts about where you would like to see this used once Tim's a little further down the path?
Well, I'd like to see it used particularly for the health screening, because I think prevention and early detection is key, because it reduces the resources that we need upstream. And I think, as we've discussed, the advantage of that is being proactive with somebody's care and they take the initiative. And for me, the only way that we're going to save the health service or any health service is to stop people getting sick. At the moment, we're just overwhelmed with illness. And I think Tim did a very good description of that. No matter what chronic disease you've got, we just don't have the staff, we don't have the resources, and protecting all health systems have to be about early intervention. Finding the benefit for this, for me, is it also picks up those who are at high risk of the other major killers, type 2 diabetes, heart disease, any of the metabolic syndrome components. It's going to find our biggest people at risk, and we can implement this in children, so we can pick them up this much earlier because it is based on bloods. So the potential to turn the system around to be what it's supposed to be, for me, out of something like this is actually vast. For such as Tim, I'm sure he's doing himself a disservice by saying it's quite simple, but we like to keep it simple, stupid on this programme. For such a potentially simple system to have ramifications, I'm excited by that, because it picks up the right people that we need to be scanning, looking ELF and all of that, getting them in quicker.
Jörn, what do you think?
Yeah, it overcomes the challenges of not having a hepatologist sitting in each office. And then again, even hepatologists don't think or ask the right questions all the time. So, I think it's an augmentative support tool. It can operate in the absence of a physician and refine patients. And you can probably, fine-tune according to what you're looking for. So, the condition of interest could probably be adapted over time, Tim, if I understand correct. And that might be helpful, in terms we have certain labels that we want this patient, not that patient, or it might be different in a different system, cost effectiveness. So I think it's a very nice way of moving forward.
I agree. And one of the things I like that we've not mentioned yet exactly is, Tim, you referred briefly to the black box systems before. Some of the black box systems are designed to do very, very fast screening throughput of populations with well-organized electronic records. But what they don't have at the back end that you're describing here is an optical validity test, where you can turn around, show a screen to a patient, patient goes, got it. When I said through line on complexity, it was not only can you sift through a lot of data quickly, and not only can you organize and prioritize it, but you can then help people visualize it, so you don't really have to know very much about what you're talking about to see a picture and say, okay, I know what that means. That means I got a problem. Louise, I don't know why you're laughing, but I think that's a pivotal, to me at least.
It was the comment of you don't really need to know what you're talking about.
Louise, I've done 165 of these episodes and I never knew what I was talking about in the first place, so it's not a big deal to me. Yeah, go ahead, Tim.
So it's bridging that gap, isn't it? I think this is one of the fundamental things that some of the conversations I had recently, the gap between population health and an individual patient sitting with a clinician, whether it's a diabetologist, a hepatologist, or whatever. So this is a tool that will bridge that gap. We have incredible data sets, incredible insights into our population health. We also have amazing research that says how to treat the patient in front of you. But we still have that missing gap. How do you funnel through all the patients in the population and get the right ones in front of the right clinicians at the right time so that you can intervene? And it really does bridge that gap, because I can put an algorithm together and narrow down 500,000 patients to 25 of interest who meet the criteria. We set the thresholds wherever we like. We set them lower and we'll see more, but you can really focus in on the ones. And then that's a manageable number. And I think population health is often, the numbers are just too big for us clinicians to conceptualize how we're going to approach this problem. And the answer is you're going to find the patients who need you most, and you're going to treat those ones first, and then you're going to move on, and you're going to intervene, and you're going to prevent problems. And it's bridging that gap.
Tim, unless anyone objects, I'm going to let that be the last comment, because I think that was really great as a wrap-up. So with that, Tim, we wouldn't have gotten you on any sooner, even if I'd seen you in the restaurant that night in D.C., because this was going to be the first week we had. So I'm glad that we got, one way or another, I'm glad we got to do this week. This has been a fantastic episode and a fantastic experience. I will be back with the business report in a few minutes. Louise will fly to Australia and be back next Monday running an episode. Jörn will be with her then, whatever time it'll be for him when she runs it. And then I'll see you in 2 weeks. And Tim, hope to have you back in 6 months or a year when you got more data to let us know what you're learning, because this is fascinating stuff and important. And with that, let me thank you three for joining us on the episode.
And now for the Season 4, Episode 5 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine. When this war started, one fear was that if it continued into winter, Russia would shut down its gas reserves, and the cold weather and freezing temperatures would break European resolve. With warmer than usual winter temperatures, and the U.S. and other countries picking up the slack on natural gas, this appears to be one more threat that didn't hold up. Let's hope the weather and gas logistics continue to cooperate.
Roger's weekly pitch for reviews starts now.
Last week, I discussed the value of reviews coming through your podcast distributor in terms of helping us raise the podcast's Apple ratings, SEO, and overall visibility. We've not seen anything yet. I don't know how long these things take to surface with us once they're written, so you may already have written one, and we may just not have it yet. If you haven't written one, please do so. If you have, please do so. Same message either way.
Last week, Roger misspoke about future episodes.
I gave you a whole paragraph about this subject last week, almost all of which was wrong. 1, we're still sorting out our final list of 2023 conference coverages, and since I'm on vacation much of the next week, that will not get released until early February at best. 2, Louise's episode from Australia will post on February 1st, not February 6th. 3, the digital episode will post on February 15th. The pediatric episode will post on March 1st, and it is the February 15th episode, which will be sponsored by Towers in Health, that will give you your first chance to hear about Louise's My365 app.
The Vault returns for another year of memories.
The Vault conversation returns from the 2023 season. Our first Vault of the year comes from last August, Season 3, Episode 39.3. In this episode, Ian Rowe joined us to discuss different models for frontline patient screening. And this conversation touched on some of the specific challenges related to screening and patient information, some of which we discussed today with Tim Jobson, but from a very different perspective.
And the download beat goes on.
I mentioned that one day 2 weeks ago was our biggest download day ever. Well, in the past week, we followed that up with a 2-day spell was our largest 2-day download ever, and the first time we cracked 2K in responses or in downloads in a 2-day barrier. After a really anemic first week, January 2023 is on track to be among our 5 best months ever, maybe even our top 3 months ever. So with that, I'm off. Thanks to Jake, Magic Mike, Eric, Steve, everything you do, particularly to them and Louise for covering next week while I'm away. So enjoy this episode and the weekend conversations. Monday, Louise will be back from Western Australia, what Jake has told me is known as the Perth dimension, to introduce us to NASH and Oz, and I'll be back the following week. And until then, stay safe, surf on, Louise, and then we will see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.